hi there. Hi again. Let's see if we can get Dr. Khan on this time. We're going to try. Let's see. Doctor. Oh, let's see. Here we go. Thanks so much for hanging in with me, guys. I feel like we always have a technical difficulty here. Okay, let's see. Good. Let's see. I think I did it. Let's see. Hi, everybody. Thank you for jumping back on with us. Hi. Oh, I'm upside down. Okay, let's see if I can fix that. Is that better? I'm trying to make it so that we'll see Dr. Khan, too. Hi. Hi, everybody. Let's see if we can fix this a little bit here. All right, now we're just waiting for Dr. Khan. He had some technical difficulties last time, but I just talked to him on the phone, and Facebook's giving him a hard time. Hi, Dr. Khan. Okay, let's see. Let's try. All right, let's see if it lets us do it. Oh, it looks like it might. All right, it says it's adding him finally. Let's see what happens. Yay!
Hello? Yes.
Oh, you're sideways. Hi, Dr. Khan. Let's see if I can fix this or not. I feel like it may or may not let me do it. Let's see. I'm going to try. Let's see. It's not doing it. Whoop! We're going to make everybody dizzy. Hi. All right, let's see. We might have to turn your phone, Dr. Khan. You're upside down now.
Sure. Do you want me upside down? Okay, let me go ahead and rotate my phone down.
No,
Okay,
you
am
were
I
right.
better?
One more way.
Okay,
Good.
got it.
Stop
Like
right
this?
there. Hi. Yes.
All right. Now that sounds
We
good.
did it.
All right.
Yay. Hi, everybody. Okay, so we had a ton of people waiting last time. I feel so bad, but Facebook always gives me a hard time. It's not our fault, Dr. Khan, I swear.
Sure. No, and I appreciate it. And at the end, all's well that ends well. So I'm glad this is behind us.
That's
and
right.
So we can go ahead and move forward and answer any questions that we may have.
Great. And let me just tell everyone a little bit. So Dr. Khan and I did a huge startup in our last video, but Dr. Khan is giving a lot of his time to our BII community, and he's here tonight just to help answer some questions. I know we already have women asking lots of questions, so I appreciate you all joining us, and it's so generous of Dr. Khan to share your time here with us in the breast implant illness community. And as I mentioned in our last little clip video, that you only ever put in one set of implants, and that was to become board certified. Otherwise, you couldn't. But that's how dedicated
correct.
to the breast implant illness, community you are. And I think for so many women who have heard that there's no such thing as breast implant illness and that they're ridiculously crazy, this is such, a nice, refreshing thing to hear, right?
Yes. Thank you very much, Darby. It's a pleasure for me to be here and to join your group of followers and everyone else, to those who are not listening. And hopefully, this will provide for a nice platform, a nice discussion. We all have been living with a lot of signs and symptoms, and hopefully I can shed some light from my experience and my expertise of being a board certified plastic surgeon and what I have noticed over the years. And, as I got trained, and I've been fortunate to have trained at very fine and very nice institutions, such as Yale, which is where I started my surgical experience, and also at Case Western, and now here within Detroit at the Beaumont system, the Providence Park system, and also within the DMC system, where I trained. And then I basically continued, and this is, just a little bit about my credentials. I'm a board certified general surgeon, which means that all the trauma, gallbladders, colon resections, among mastectomies, I have been officially trained. I am also a burn surgeon. That was a 2-year commitment. And then following that, a board certified plastic surgeon with the ASPS board certification and authentication. So I'm here, over the years, I've seen a lot of women, and the jewel and their bread and butter, if you will, almost half of plastic surgery is chest reconstruction.
Wow.
And
no
breast
clue.
reconstruction. And I will tell you, as we all know, the most common procedure that is done is the augmentation. And so this is where, we have our expertise. And I am fortunate enough to have trained right here in town in Michigan at Carmanos, the #1 cancer center. And then also very nice plastic surgeons who are seasoned. And I've been blessed to have a very nice training.
That's amazing. You are obviously extremely well trained, and that is so, it's so refreshing just to hear, you know, that we've got someone so wonderful on our side. So we do have a couple questions, and you know, we're gonna chat, and then we'll just throw in some questions as we go. If we don't get to everybody's questions, you can always message afterwards. As I mentioned, Dr. Khan is so generous with his time. I can always send questions to him, and then we can get back to you at some point if that's okay with you, Dr. Khan.
Absolutely. And, you know, we can, if you want, Darby, you know, I look at this as, you know, I've been privileged to have this education. I want to go ahead and share it, not with the viewers, and hopefully share the information that we all know exists, and so that everyone understands what is really going on and where we stand in 2019 in regards to this. Where were we in
Yeah.
1992, for example, or 2007? And we learn from the past so that we basically make very informed decisions about the future.
Okay, so
And we
the
can
first
continue this as a part 2 series later on. We can certainly
sounds
join
great.
again, and hopefully this becomes a very productive way to communicate information.
Yes, this has been really helpful as far as other things that we've done, other ones. Okay, so the first question that we have is there a way to tell if the doctor left the capsule in the body if he hasn't been forthcoming with it? So that's an unfortunate question, that's
That's
something you feel you have to ask, but is
That's
there?
a very important question.
Okay,
So the best tool to now, we need to look at proof. We need to
okay,
look at evidence, and we need to look at hard evidence in a sense that you can reproduce it.
okay,
By that I means, for example, if you can imagine, some of the capsules are so thick that you can actually feel them on the chest. So these are the ladies that have grade
like
3
through the
and grade
skin?
4 through the skin, because if you look at capsular contracture, there's 4 different grades, grade 4 being the most severe, where the women not only feel a distorted chest image that anyone and everyone can see, but also they have pain at rest, and you can see that the chest actually gets deformed. And we know during those cases, before going in clinically, that you can actually palpate and feel the hardening of the chest. So
Wow.
that if someone hugs another person, and the lady with grade 4 capsular contracture, they're actually going to feel the chest pain. So we
I've
know,
had
and I
women
know
complain
going
about
in,
that. Yeah.
yeah.
Now that I'm
So
thinking
I know,
about it.
and you know, everyone develops some sort of a capsular contracture. Some maybe after 10 years, some maybe after 4 months. So we
Interesting.
know from a clinical exam, you can actually feel the hardening. So women who come to me and they feel like their chest is rock hard solid, this is the grade 4. So number one, to answer your question, women will be able to palpate if the capsule is left behind underneath the breast tissue, that there is hardening and thickening of that capsule, the same capsule that I've been cutting that you've been seeing on my YouTube videos. Number
Yeah.
two, the best modality we have is the ultrasound. You know, if you can imagine, you know, again, an ultrasound over
That's
a liver,
good.
or
Okay.
for example, you can see in the gallbladder stones, sludge, even a 2 millimeter stone, you'll be able to pick up in the gallbladder, for example. So the
Okay.
point being, if a capsule is left behind, all what
Get an
one needs to
ultrasound.
do is get an ultrasound or even a mammogram, and you will see those calcifications amongst the many other hardening, abnormal soft, hard tissue, and even thickened tissue or scar tissue. So one lady that I just talked to yesterday, she called me up, and I operated on her in 2018, and I hope she's listening. She said, "How do I know that you got the entire capsule out?" I will tell you, all what you need to do is get a mammogram, because remember, the mammogram will pick up on calcifications like it does pick up on, for example, when someone has breast cancer,
Okay.
or the ultrasound, which is a very specific, very sensitive test where any calcifications will be picked up, and
Okay.
especially when you're right on the chest. If you can imagine a fetal heart sound and the valves of the heart of a baby fetus can be picked up, you can only imagine small calcifications. So the ultrasound
That's
is
true.
another modality where you will be able to, and the ultimate of all the tests is the MRI, which is the best test we have, which will pick up, which the FDA regulates, and we know from our textbooks that it will pick up on ruptures, among leaks, among any soft tissue problems. So these
Okay.
are the 3 modalities in addition to the clinical exam that will pick up any left capsule behind. So post-op, any patient, and I say this with confidence, who gets a mammogram or an ultrasound a year out, which shows capsules that are left behind, you know that it was not entirely removed at the day of the surgery, period.
Okay. Okay. That's wonderful answer. That's That's wonderful. Hi, everybody. Hi, I have a lot of people coming on. Okay, so the next question, I do want to address it so we don't forget, is earlier today I messaged it to you. And I think essentially it was the importance and what's the difference between en bloc and why is it so important to take the entire capsule out. And I know we get this question all the time because there's a lot of doctors that are trying to keep it in. And if you listen to Dr. Khan's podcast that we did together, you'll hear the reasons that he says it's so important to remove it. But I think it's important to reiterate it here, and I would love to hear your answer.
Sure. So the en bloc, you said, what many people ask, what's the difference between en bloc versus a total capsulectomy versus a capsulotomy? So en bloc means, as you've seen on my videos and like I've explained, you remove the implant and the capsule around it as one system, so that if there is a rupture, calcifications, whatever it may be on the inside, mold, an abscess, a rupture, all of that is contained, so that when you open it afterwards, once the patient has left the operating room and you're done doing the surgery, if there's any spillage, you're not going to be leaking that silicone into the chest wall or those silica particles.
Right. And now so that, let me just stop you just for a second. When we spoke on your podcast, you said that they were finding silica. So if you see those little baggies that come in all your vitamins or any of your protein, that's silica. You said you were finding silica in women's breast tissue and their lymph nodes, right?
Yes, so not the lymph nodes, because normally the lymph nodes is a separate dissection within the axilla.
It was just the breast.
And so, yeah, so normally, so my goal of the operation is to go in, remove the implant and the capsule, and so that both of these come out as one piece. Now, what I have done, and I just texted you, and we certainly will have this posted, I've taken the capsule and sent it off to pathology, and what they do is they do light studies where they have polarizable light and it refracts in a certain way, and then that way they can say, as you will see in the path report, which is the final path report of one of my patients, it says consistent with silica, and so that's a fact. Now there are patients that I have gone in, and this is the rare of the cases, where I go in into the chest wall and into and above where the implant is, but the capsule is very benign. And it's basically as if you had just inserted the implant like 2 months ago, for example. And so in that case, which is rare or rare situations, this is very analogous to saying, if I may, someone gets a laceration or a cut on their hand or on their face. One person may heal so well that a couple of months later or 4 months later or a year later, you will not see a single scar.
Right.
Another person, same injury, may form a keloid where you have an outpouching / disfigurement amongst the others. So this is the scarring on the inside, if I may use that as an analogy.
Sure.
Now, majority of the times, why are the ladies hurting? Because you inevitably develop capsular contracture over time. And so I say, you know, if you have sign symptoms, almost always your body's trying to fight this off. Now, sometimes I have gone in and the capsule is as benign appearing, and it's like a very thin, wet tissue paper. It's very hard to remove, and you have to essentially scrape that off. But I will tell you, get the mammogram the next year or the ultrasound, you will not see the residual capsule because it's on the palpation. It is very, very thin, and it is not a problem, meaning it doesn't have the silica. As opposed to vast majority of the patients, you have to remove the capsule because that's where the badness lies. And let alone next year when you get the mammogram, you don't want to be in a situation where now they're finding calcification, thickened tissue, as you see, and now it is a concern. Is it cancer? Is it malignancy?
Sure.
Is it silica? And guess what? It throws the patient off and the doctor, and now all of a sudden you have unnecessary biopsies that are being done because it is abnormal thick scar tissue, as you've seen in the videos and the many capsules that you see on social media. So to answer your questions, majority of the times the capsule is thick, it's abnormal, it needs to be removed with the implant and blocked, because you never know till you're inside the chest that the capsule is very benign, which is a relatively rare case, but majority of the times it needs to come out. So to answer your question in summary, The capsule is the body's own way of walling off this foreign body. Just
Sure.
like someone has a pacemaker, someone has
Yeah.
a port for a lap band, it's a metal, or a implantable pain device. What the body inevitably does is, this is the ways it defends itself, it forms a capsule around it to
Right.
wall it off because it recognizes it as foreign. Now we're dealing with metal, titanium, stainless steel, or hardware, artificial hip, artificial knee. Now, what is happening is that with the silicone, be it saline or the silicone or the saline implants,
Mm-hmm.
your body forms this abnormal thickened scar tissue around,
Yeah.
which is the capsular contracture. That thickened abnormal tissue has silica in it, as you and I know because of the pathology.
Right.
That needs to come out so that when I got done on my exam, when I'm done with my surgery, I actually feel on the inside and I don't feel any hard or scar tissue. And there's nothing hard that I need to remove because all of it has been removed.
That makes perfect sense. So I do have this. That was a wonderful answer, and I hope that answered the question that she had. I feel like that gave me so much information. I'm learning so much. So I'm so excited. I'm trying to take all this in. So there is a question that has been floating around our implant group, and I think it's very interesting. And I'm wondering. I think it might just be an opinion, but who knows? As women, we have noticed that scarring tissue or after explant, the left side either has a harder time healing or it's got more issues. It's if there's going to be some deformity or some type of deflation, it seems to happen on the left side. Obviously, that's over the heart. For me, the doctor who removed mine said that I had a lot more scar tissue on that side. And I was wondering if you had an opinion or what you thought of that.
Sure. So that's a good point. And I will tell you anecdotally on my many patients that I myself have seen, the left side seems to be more the problem side, be it
Okay,
pain,
so you're seeing
contracture,
that too.
just that
Yeah,
it, and I will tell you, this is anecdotal. This
sure.
is my personal, and I've heard this on and off from my friends, other plastic surgeons that I've talked to, but I will tell you, this has not been a proven, and this is what I was telling you earlier. We need to have proof, we need to have documentation, and we need to have studies. And I will tell you, as a board certified plastic surgeon, in any of the textbooks and the papers and journals and meetings that I've gone to, and we have looked at literally hundreds of thousands, someone would have picked up on this fact, they would have done the studies. And
Yeah,
I will tell you, this is just your observation and my observation, which in
sure.
reality is not reality. Because there
Yeah.
is no, someone would have picked up on it and
Maybe they
said, well,
will.
it seems
Maybe
to
they
be,
will.
yeah, maybe they will. Yep. And so I will tell you, this is something that is not concrete, and this is just
Sure.
anecdotal.
And I did just ask for your opinion, but it has something. I think probably 50% of the women talking about it, maybe more, are telling me that I haven't heard anyone say their right side is worse, actually.
Right.
Scratch that statistic. I haven't heard anyone say that. They all say they're having difficulty on their left. So that's interesting. So please let us know if, yeah, left side, left side, left side. Yes, our comments are saying yes, left side, left side. So, okay, so that is interesting. So, it's good to just kind of get an idea. And I have another question for you as well coming up here. We did finish that last one, right? We finished that last question.
Yes.
Okay.
Can I just add one more thing?
Sure.
So, as you will see, so going back to the first question, which is very important, if you ask me the gist of this whole discussion we're having, it's just that one question.
Okay.
Do I leave the capsule behind or not? No, on
Right.
the exam itself, if it is abnormal, it needs to come out because, as you know, we're very soon, once we get done with this, you're going to post on your Facebook that pathology report, which says that the capsule that was sent to pathology, and I sent all of my capsules to pathology because remember, 8 out of 9 women are going to get breast cancer. We don't want to miss something, and obviously,
I wish
we
I
will
would have
see
sent
and feel.
mine.
Yeah.
I didn't.
So because we want to make sure we're not missing something, and you will see that capsule comes back as silica. If you leave the capsule behind and the implant is out of the body, you leave the capsule behind, what's going to happen? The body is going to continue to mount an immune response like 10% or 5% of the implant was left behind because it has
That's
bled into the capsule. And
okay.
then you may not recover 100%, you may recover 70% or
That's it. That's
80%.
the answer to so many questions that so many
Right.
women have been asking.
And
So how can you figure that out if you don't know if anything was left behind, and you didn't, like me, I didn't send my, I mean, the doctor gave me an option. She said she didn't see anything abnormal, so I didn't send it off to pathology. So how do I now be proactive? I don't have my capsule. I donated it to
Sure.
research.
So I will tell you, there are, from my experience and expertise of talking to women and having done a lot of explants, 5 things that I say that you need to be on the lookout for, which
Okay.
is, and I will tell you, each and every single one of you is the judge, and you think about, within reason, whatever I'm saying, but this is what I would say: proof that the capsule was removed. And there's
Okay.
6 of them. Number 1, you have a large incision. You cannot do an end block or a total capsulectomy, which is you remove the entire capsule, but during the surgery, the entire capsule was removed and blocked as one system. So you have a 10, 11, 12 centimeter incision at the inferior mammary fold. If someone says, well, I got the end block from a 2 or 3 centimeter incision, that's virtually impossible. Because how can you remove that entire ball, if you will, the size of a grapefruit or smaller, an orange, from a 2 centimeter incision? That's virtually impossible.
Okay.
So number 1, you look at this size of the incision. Number 2, you look at the time it took for the surgery. To do a real end block, it's a 4-hour commitment. Yesterday I did 3. And I will tell you, I started at 8:30 and I didn't finish till 8 o'clock last night. And I will tell you, so if someone says I did an end block in 2 hours, you cannot fly from New York to San Francisco in 2 hours. That's virtually impossible. So the point is, you have to look at the OR time in, OR time out. If your surgeon did 6 of these a day, he should have finished in 24 hours. And that's what I say, because I do these a lot. From the time you go in and prep, it probably is 20 minutes, 30 minutes to even before getting started. And to do an end block, depending on the expertise of the surgeon, it takes time. And so on average, whenever I book for 4 hours. So that's the second thing.
I'm writing these down. I'm going to post these in the comments, ladies.
Sure. Now, the third thing is where you have implants that are given back to you. So sealing implants. There are some surgeons, with all due respect to them, they're like, oh, we're not going to give you the implants back. And I say, the implants are the patient's property. Yes, we respect that, but you give the implants back, because that's another proof. Let's say if you have saline implants and you got them back, you knew they were removed as one piece, as one system, because many times the implants are ruptured. Okay. No, they purposely break it, leak out the saline that's in it. And then what happens next is you have then created the implant deflates. And then what happens next is you have a smaller incision that you can remove from, which many people say, well, why do you want to make a big incision? Well, it's an incision on the inferior part of the breast. No one's going to see. It's going to hide very well. But you want to get the implants back, is what I'm trying to say. It's proof if you have a saline implant, it's not ruptured, it's intact, that it was taken out as one system through the end block technique. Number 4, you have to get pictures. Each and every single picture is now fingerprinted, if you will, or had is a stamp as to what time and where it was taken. If you kind of allow Google Maps or, your, so you can see, normally what I do is I write the date, and I also write the patient's initials, so that when I take the pictures, the patients understand that this is their initial. It was that, sir, that.
I have photos like that. Mm-hmm.
Right. So it's very important, and again, just to be transparent, so that ultimately the patients understand that, this was done, otherwise you really do not know if it was done the right way or not. So you want to see the pictures, and, I will tell you, it's very important, you cannot have a surgeon that will say 100% of my surgery or 100% end block. That is virtually impossible, because to tease that capsule off of the chest wall, it is a most difficult part of the case, and it's not an easy surgery. And I will tell you, not many surgeons can do it. Not all surgeons can do it. And you have to have that expertise and the experience to feel comfortable dissecting off of the rib cage, because a couple of millimeters down is the lung, and you will puncture the lung, and you'll have to put a chest tube in, which necessitates a visit to the step-down unit or to the intensive care unit, because you're directly into the lung space. So that's the 4th thing that I just mentioned. And the fifth thing is the surgeon's reputation, you know, across the country, you know, and this is where I say, where a surgeon can say, you know what, I feel your pain. I believe in breast implant illness wholeheartedly, to the point where, you know, good for them that if they come out and say, I don't believe in putting him in, that's exactly how much I believe in the breast implant illness, because there's
And there's a
different.
couple doctors that have finally started to, you know, really switch around, which is awesome.
Right now. So, for example, I'll mention, we all know, you know, if I have Dr. Fang, for example, Cleveland, a very nice, noble lady. Dr. Chan, very honorable, very nice, very experienced, very seasoned explant surgeon, and we all know they have a reputation and they really want to help. You can see it in their eyes. And, you know,
There's a
there's,
Florida
for example,
doctor who just
there's a Dr. Barr, Barr, who after 33 years of practice around the 4th of July weekend came out and said, enough, I'm not going to go ahead and do that. I believe in the breast implant illness, to the point where I'm not going to put him in, and good for him. And
I heard
hopefully,
Dr.
you know,
Rankin
as I,
also.
Dr. Rankin, yeah, so good for him, because I will tell you three things, and these are facts. It's a lot easier to put him in,
Sure.
hands down. Number two, half the time or 1/3 the time, and a lot less headache, where the surgery itself is a kind of your much simpler dissection, much easier. You're not as tired, you're not as focused, meaning, in a sense, when I use the word focused, every surgery is involved, but in order to do a end block you out physically, it really taxes you out mentally, and you're tired. It's like, and I always tell my patients whenever I walk out, I feel like I just ran a marathon, because that's the level of mental
Concentration,
and physical endurance, concentration. And so that's the fifth thing, where the surgeon has a reputation, they have a personality, and they have a recognition within the medical community and within the patient community and all these Facebooks, that this person believes in it wholeheartedly, to the point where they're not putting in implants. And I will tell you, this is from 2003, ever since I was in the surgical training at Yale, and then thereafter I saw a lot of happy patients with implants. But then I also saw over the years, as I talked to you previously, a lot of patients who were not truly happy, and they were living with arthritic pain, joint pain, hair loss, fatigue, you know, amongst the